Welcome to my Practicum Project implementation of Q2 turn boards by Erin Copeland, Grand Canyon University, Wednesday, September 17th, 2025. Overview. This Practicum Project presentation explores the implementation of Q2 turn boards within a long-term acute care hospital to reduce the risk of pressure injuries and improve documentation compliance. Patients in LTACs are often critically ill and highly vulnerable due to conditions such as ventilator dependency and neurological impairments. Because immobility is a primary risk factor for pressure injuries, frequent repositioning, at least every 2 hours, is an evidence-based practice recognized as an essential for preventing harm. Unfortunately, compliance with Q2 turning protocols is often inconsistent, particularly when it comes to documentation. This project sought to address this gap by introducing turn boards in patient rooms, which required nurses and CNAs to initial each 2-hour interval after repositioning patients. The intervention provided an immediate, visible record of care, thereby increasing accountability and supporting supervisors in conducting audits. This presentation will outline the problem statement, objectives, implementation process, audit methods and results, leadership responses, sustainability planning, and the broader impact on patient outcomes. By the end of this presentation, the importance of linking evidence-based practices with accountability measures and leadership oversight will be clear. The project not only addressed a pressing clinical issue, but also emphasized how simple interventions can make a meaningful difference in patient safety and organizational performance. Introduction and purpose. The purpose of this practicum project was to strengthen patient safety by improving compliance with Q2 turning protocols. Pressure injuries remain a common and preventable complication in patients with prolonged immobility, and they are closely linked with hospital quality metrics. These injuries prolong hospital stays, increase healthcare costs, and negatively impact patient outcomes. In addition, they are often considered never events, meaning they should not occur if appropriate preventative measures are in place. This makes them a major area of focus for CMS surveys and hospital quality audits. At my practicum site, it was evident that while staff understood the importance of repositioning, documentation was inconsistent. In some cases, turns were performed but not recorded, which undermined the hospital's ability to demonstrate compliance. The Q2 Turn Board project was designed to close the gap by implementing a clear, standardized, and visible documentation method. By requiring staff to initial the boards at each interval, the project enhanced transparency, accountability, and ease of auditing. The initiative also supported regulatory compliance, which is essential for maintaining accreditation and reimbursement. More broadly, this project illustrates how targeted interventions can create meaningful improvements in patient safety while promoting a culture of accountability among staff. Problem statement. The core issue addressed by this project was inconsistent compliance with Q2 turning protocols and incomplete documentation. Pressure injuries were becoming a concern within the LTAC unit, raising the risk of CMS citations and undermining patient safety goals. Staff sometimes repositioned patients without recording it, while in other cases, documentation was entered in the EMR but not visible at the bedside. The lack of transparency created problems during audits and CMS reviews, as it appeared that patients were not being repositioned. Documentation gaps also undermined leadership's ability to accurately track compliance and identify performance trends. Literature indicates that incomplete and inconsistent documentation is a frequent barrier to quality improvements in healthcare, particularly in high acuity settings. Without reliable documentation, it is difficult to hold staff accountable or demonstrate compliance to regulatory agencies. The problem therefore extended beyond clinical practice to include organizational accountability. This project sought to resolve these issues by introducing a visible, standardized method of tracking compliance directly at the bedside by addressing both patient safety and regulatory requirements. The project positioned itself as a practical solution to a critical quality concern. Project objective. The primary objective of this practicum project was to standardize Q2 turning practices through the introduction of bedside turn boards. Each board included time slots for every 2 hours, where staff were required to initial after repositioning the patient. The intervention had three main goals. One, increase the consistency of patient repositioning. Two, improve the accuracy and transparency of documentation. And three, reduce the risk of pressure injuries by ensuring protocols were followed. The boards served as a reminder for staff and a tool for accountability, as they made documentation visible to supervisors, auditors, and even patients' families. This visibility encouraged compliance and helped reinforce the expectation that patient safety is a shared responsibility. Another key objective was to align the project with regulatory expectations by ensuring consistent documentation. The hospital could demonstrate compliance during CMS audits, reducing the risk of citations. Research supports the use of structured tools and reminders as effective strategies to improve adherence to clinical protocols, particularly when staff are managing complex workloads. The Turnboard project was therefore designed to bridge the gap between clinical practice, documentation, and regulatory compliance. Implementation process. The implementation process began with introduction of Q2 turnboards in all patient rooms on the LTAC unit. Prior to rollout, all RNs and CNAs received targeted education on how to use the boards and why the intervention was necessary. Staff were reminded that Q2 turning is an evidence-based practice that reduces the risk of pressure injuries and aligns with CMS expectations for quality care. Education sessions emphasized the documentation was just as important as performing the intervention, as incomplete records could lead to citations during audits. Supervisors and resource nurses were also trained to use standardized audit sheets to track compliance. Random audits were conducted to ensure staff were initiating and initialing the boards correctly, and results were compared with EMR documentation. This dual approach allowed leadership to identify gaps in real time. Feedback was provided immediately if boards were incomplete, reinforcing expectations, according to Kim Smith and Brown. Combining staff education with ongoing monitoring and accountability is essential for sustaining quality improvement efforts. The implementation process underscored how leadership, education, and auditing can work together to drive compliance and patient safety. Audit methods. To measure the effectiveness of the intervention, we took 15 patient rooms and audited them. Supervisors used standardized audit sheets to compare bedside boards, entries with EMR documentation. This approach provided two layers of accountability. It ensured that turns were being performed and that documentation was consistent across both systems. The audits were conducted randomly to prevent staff from modifying behavior only during scheduled checks. Literature highlights the value of multi-source auditing, which captures discrepancies that may be missed when relying on a single documentation source. For example, some staff documented turns in the EMR but failed to update the bedside boards, while others did the reverse. By incorporating both tools into the audit process, the hospital was able to obtain a more accurate picture of compliance. The methodology reinforced accountability at both the bedside and organizational level. Audit results. 12 rooms were totally compliant, both in EMR and at the bedside board. 3 rooms were non-compliant. The audit result revealed 12 out of the 15 audited rooms, that would be 80%, were fully compliant, and the new Q2 turn boards process was successful. 3 rooms were not compliant. Of these, 2 documented repositioning in the EMR but failed to complete the bedside boards, and 1 room had no documentation in either system. These findings highlight both the strengths and limitations of the intervention. The high compliance rate demonstrates that most staff understood and embraced the new process. However, the 20% noncompliance rate underscores the need for continued education and reinforcement. Literature suggests that such discrepancies often result from workflow challenges, unclear accountability, or staff resistance to change. The results provided valuable insights into how the intervention was functioning in practice and where improvements were still needed. I included a graph and pie chart visualization on the next slide. Here is a visualization of the audit results. Analysis of findings. The findings indicate that the project was largely successful, with 80% compliance across audited rooms. This shows that the majority of staff were following the new protocol and documenting it appropriately. However, the remaining 20% highlighted persistent challenges, particularly with staff who relied solely on the EMR documentation or failed to document at all. These gaps underscore the importance of continued reinforcement and education. Research emphasizes that sustainable quality improvement requires addressing both system level barriers and human factors, such as forgetfulness or resistance to change. The findings also reinforced the role of leadership in sustaining compliance. Supervisors and department heads must remain vigilant in auditing. Prolonged feedback and reinforcing the expectation with both EMR and bedside documentation are required. This analysis demonstrates that while the intervention improved compliance overall, sustainability depends on continuous monitoring and reinforcement. Adjustments and CMS response. During week 3 and 4 of the project, CMS auditors identified gaps in documentation compliance. In response, the chief clinical officer mandated that all department heads conduct re-education sessions on the Q2 turning protocol. This reinforced the importance of accountability and prepared the hospital for re-evaluation. The involvement of senior leadership demonstrated organizational commitment to patient safety and compliance. Regulatory oversight, when combined with strong internal leadership, can act as a catalyst for lasting quality improvement. The CMS response highlighted the importance of external accountability in driving change and underscored the need for continuous vigilance. The experience also emphasized the critical role of leadership in responding quickly to deficiencies and ensuring that staff remain aligned with best practices. Sustainability plan and next steps. To sustain the improvements achieved through this project, a long-term plan was developed. The plan included 3 key strategies. 1, continuing random audits to monitor compliance. 2, reinforcing staff education on an ongoing basis. And 3, integrating Q2 turn board compliance into organizational performance metrics. Random audits will ensure that staff remain accountable, while regular education will address turnover and reinforce expectations. Embedding compliance into performance metrics ensures that the initiative becomes part of the organizational culture rather than a temporary project. Literature emphasizes that lasting quality improvements requires integrating new processes into the daily routines and performance frameworks of the organization. By aligning the intervention with broader patient safety goals and accountability systems, the project is positioned for long-term success. Conclusion. In conclusion, this practicum project demonstrates the implementation bedside Q2 turn boards is an effective strategy for improving compliance with repositioning protocols and reducing the risk of pressure injuries. The intervention addressed a critical patient safety concern while also strengthening regulatory compliance. Audit results showed high levels of compliance overall, with remaining gaps highlighted the need of continued reinforcement. The CMS response further reinforced accountability by mandating re-education and preparation for re-evaluation. Sustainability strategies, including ongoing audits, staff education, and integration into performance metrics, will ensure that the improvements achieved are maintained over time. Ultimately, this project illustrates how a simple evidence-based intervention combined with leadership oversight and staff engagement, significantly improve patient outcome and organizational performance. Literature supports the conclusion that education, monitoring, and leadership are essential components of successful quality improvement initiatives. And our references.